Good morning. Dr. David P. Winchester, and I'm a surgical oncologist and medical director of the National Cancer Programs at the American College of Surgeons. Yes, in fact, we have some very recent information. This is from the National Cancer Database. It's housed here at the college. Has about 30 million cancer patients in it and a very large cohort of breast cancer patients. And this was presented at the Western Surgical Association about 5 or 6 weeks ago. It's a study from the National Cancer Database conducted at one of our hospitals that has access to the file. It's called a participant user file, and that's at North Shore Medical Health Systems in Evanston, Illinois. And that is a large study of about 550,000 women from 2003 to 2010. And we looked at the trends for lumpectomy, mastectomy, and bilateral mastectomy, and saw some really striking trends. Overall, lumpectomy stays around 60 to 65 or 66%, but the double mastectomy rate has increased over that period of time from 2003 to 2010 from about 4.1% to 9.7%. Furthermore, if you look at it by age, it's really striking. For women under the age of 45, that rate was much higher, and especially for women under the age of 35. In 2010, 34% of women with early-stage breast cancer on one side had the opposite healthy breast removed, 1 out of 3 patients. And that's an extraordinary increase. If you look at the overall double mastectomy rate from all the literature since 1988, it's up about 150%. Yeah, for no previous or concurrent history of breast cancer, the most common reason for a bilateral prophylactic mastectomy in the absence of cancer is a verified genetic mutation, BRCA1 or BRCA2. That is a very small percentage, however, of all the breast cancer patients in the United States. But it remains the most common reason for women who do not have breast cancer but who have been identified as having these mutations to undergo prophylactic bilateral mastectomy. And so for the case of, and again, that's only 4 or 5% of breast cancer patients, more commonly we're looking at women who have a new diagnosis of breast cancer, early stage breast cancer, and it's in one breast, and they've been evaluated and their other breast is healthy. And in that cohort of women, those are the figures I was citing before in this 500,000 patient study, the National Cancer Database, where those numbers really increased dramatically and were very clearly tied to the patient's age. The reason for that is obviously if a woman's 35 years old and she has cancer in her right breast, her chances of developing cancer in her left breast are about 7 or 8% in the next 10 years. But if you look at her whole risk period from age 35 to say, let's say age 85, that's a long time. And the risk goes up, and up. And so they look at that and they say, well, for many reasons I'm going to do this. And this is a decision that's made by the patient and the family. But it really needs to be made in the context of an informed surgeon and one who looks at both sides of the equation and explains all the risks and the benefits. But it ultimately becomes a decision of the patient. And the most common reasons for these patients to embark upon more surgery is the leading cause is peace of mind and no further mammograms, and it does work. Erroneously, they commonly believe that it's going to improve their survival rate by having the other breast removed, and there's little or no evidence that there's any major impact by doing that. There may be a small survival benefit, but it's really not significant enough to use that as a reason. Another reason is if they're having to have a mastectomy on one side, they look at what's going to happen to the other side, and very often when breast reconstruction is done for the cancer side, the surgeon has to do something to the healthy breast to achieve a match. And so symmetry is another reason for these patients to embark upon the prophylactic mastectomy. Well, first of all, breast reconstruction in the United States has improved dramatically over the last 2 decades, but it's still fairly underutilized. But despite that, there are different ways of doing this, and the implants have been improved. Probably the best cosmetic outcome is with tissue transfer from the patient's abdomen, usually. That's a bigger operation that requires 6 weeks of recovery, 3 to 5 days in the hospital, some pain. And so the downside of having the other breast removed, if you're going to do reconstruction, and most women, especially younger women, prefer that, having immediate reconstruction, it adds another operation, it adds expense, recovery time. The reconstructed breast sensation is lost. There's an operation now called nipple-sparing mastectomy, in which the outcome cosmetically is really very good if the nipple can survive that trauma, and usually it can. That's a more natural-looking reconstructed breast. So a lot of things are going on with this. Another thing that could happen is that if they have a cancer on the right side, let's say, that needs additional treatment, like radiation and or chemotherapy, that complicates the whole situation with respect to how the reconstructed breast on the cancer side is going to look after radiation therapy. There may be complications with a complicated operation in which onset of treatment that's necessary can be delayed by having undergone this. So there are definitely pluses and definitely minuses to this procedure. And that's the sort of thing that patients need to be counseled about by knowledgeable breast surgeons. That is to say, you know, your survival is not going to be significantly affected by removing your other breast. Here are the advantages of doing it. Here are the disadvantages of doing it. They need a balanced approach to this. Well, the skin-sparing mastectomies are standard of care now. That is to say, you remove minimal amount of native skin of the breast, both on the cancer side and the prophylactic side. The question about nipple sparing is really driven by what's going on with the cancer in the right breast, as the example I've cited. If that nipple cannot be spared on the right side for cancer reasons because of the cancer's proximity to the nipple, then there's no point in doing a nipple-sparing prophylactic mastectomy because they're not going to look the same. The reconstructed nipple on the right is not the natural nipple. The natural nipple on the left would not look symmetric. So it really depends on what's going on. That's been studied quite a bit, and it does not hide recurrence. Most recurrences after total mastectomy are in the skin or the muscle, which is right under the skin with reconstruction. And so those recurrences are easily detected, and the implant, neither the implant nor tissue transfer interfere with detection. In a study that I cited originally from the 500,000 women that we studied, interestingly, the earlier the stage of the cancer, the more common bilateral mastectomy was done. And why would that be? If the cancer on the cancer side is more advanced, really the patient's longevity is going to be driven by the cancer on the right. And if it's node-positive disease, even with treatment, you need to look at the probabilities of recurrence from the index lesion on the cancer side, and then is it worth it to go through all of this with the other breast when you know it's not going to affect survival. But with women with stage 0 or 1 breast cancer, especially stage 0 breast cancer, they can feel pretty assured at the level of probably 98% long term that they're going to be cured with the mastectomy if it's necessary on the right side because of the extent of disease. And that, I think, influences their decision about the opposite side.